Okay, this is Bethany Naughton. She works at the acute therapy at the University Hospital. I'm Amy, and this is Maddie. We are interviewing you for our leadership class, trying to figure out the best leadership styles or your leadership styles and the difference between that compared to others. So, what has influenced you to get where you are today as far as your career?
Probably at my second job, I had a wonderful mentor that I felt like embodied who I wanted to be as a leader. And so I think that was a motivating factor to go into leadership. And then transitioning, knowing I wanted to go back and further my education. So after just having a bachelor's, wanting to go the leadership route. And then I did get my master's of health administration here at the university. So I think that has shaped me a lot going through that program.
Okay. What is your career path to this day? Like, where did you start and where are you now?
Yeah, so I started as a staff occupational therapist at a nursing home. And then I took a job within a year at a hospital-based system, but I ended up being able to work a lot of different areas in the hospital. So I think that was a good experience that helped shape me. So skilled nursing, outpatient, we had inpatient rehab, pediatrics, home health, and then kind of lucked into becoming supervisor in home health because nobody else wanted to cover home health. And so I said, I'll go cover home health. And after I was there, I fell in love with it and they needed a supervisor. And so then I became the supervisor of therapy. So that was my first kind of avenue into the leadership world. And then I transitioned here about, 5 years after that, and then continued my leadership role here. And then I guess I was supervisor, and then now I'm manager of all inpatient therapy. So whether it's University Hospital Women's and Children's or our Orthopedic Institute, so any inpatient therapy.
Okay. How many employees do you have?
I just looked this up last night because I was looking up today. I have about 60 at all 3 locations, counting full-time, part-time, PRN, and that's therapists. We have some rehab techs and some administrative staff.
Okay. Does your job require group tasks or more individual situations?
I would say both. So we're very collaborative. So still, we have 5 outpatient clinics. So we have a supervisor for each outpatient clinic, and so we work together a lot on different projects. But we work alone, on some things too. But we do a lot together. So I would say over half of it is more of a group effort.
Okay. What are your strengths as a leader?
Goofiness. No. Let's see. Let's see. I think I always try to act the way I would want to be treated, that I would want a boss to be. And so I think when I started here, my big goals were to be consistent, objective. What else? Let's see. I think they would describe me as easygoing and friendly. I think I like to treat others as professionals, and so we don't micromanage. We use a lot of macro managing, where we, even as all of us leaders in therapy, we have a job, we lay out the expectations, but we don't sit there and nitpick everything. We let people be professionals, and I've really learned in the last year since I took on extra responsibility. I couldn't hold on and do as much on my own. I had to delegate, but that's been a win for me and for the staff, because more direct care staff got to do more leadership type things. So it helped me have less on my plate and to help them take more leadership role in the department and ownership. And so being able to delegate has really been a benefit to me and the staff.
Okay. What is your overall career goal? Do you see yourself going further at University Hospital, or?
I love University Hospital. So I don't know who's be seeing this now. No, I really like it here. I think I've had the opportunity, even in the 5 years I've been here, to grow within this organization, and there is a lot of opportunity here, and I'm very happy here in therapy services. So I see my role continuing to evolve a little bit, but not change a whole lot, and I'd be okay with that. So we're always doing different stuff, but staying in the same basic location. We've been so fortunate to grow so much that it's been easy to stay in the same position and yet have it look different each year, because we're always doing new things. And so I see myself staying here and doing more of the same, continuing to grow.
Well, how do you communicate with your staff?
So communication is a big problem. We have a large staff,
Yes.
and each area is a little bit different, but being able to communicate is, and we have to be able to keep staff up to date, and so that's something that we focus on a lot. So we do a lot of email, and then verbally when I can, and so that's the other hard part because I'm in 3 different locations, being able to maintain that personal communication level. So I said I try to over communicate. So lots of emails. I make myself available by text messaging, paging, and making myself available after hours. That way if staff have something they need, when I'm off site, I send out my schedule. I kind of call it Where's Waldo for the week, but I send them a snapshot of my schedule so they know what building I'm at when. So if they want to have a meeting with me, they know I'm going to be in their building, and if not, they know where to find me, and I can be available by pager or cell phone, and then do formal meeting minutes for different meetings. We do in therapy services. We started sending out a newsletter each month to kind of let all the areas know the updates that have been going on. So we've really tried to work on that piece because it is difficult when you have a big group,
right,
to keep everybody in the loop.
If someone has an issue with a task, how would you address it?
Is there more clarification on the question?
As far as working with a patient who doesn't necessarily want to continue working with the therapist, or if a therapist has a problem with another project that they're actually working on, or between therapists.
So that happens quite a bit, that there's always issues. There's not a day that goes by there's probably not some type of issue. So typically I'm more of a sounding board. If you talk about the leadership role, like more my role in those situations. So I have learned to be more of a counselor or give advice, because most of those situations are handled better if the individual's involved to discuss it and interact. And so typically I'm more of a listener. Sometimes I don't give advice, sometimes I just listen. Sometimes a leader's in a hard spot because you can't give advice without maybe saying negative about somebody. So sometimes you have to really work hard to stay neutral, not take sides, but just give advice. Sometimes pointing them in the direction of, what did you think about, this idea, or maybe the person was thinking this. A lot of our issues in this building, I would say 90% of them are probably an education issue, and that's what I've really pushed staff to understand is if you have an issue with somebody, if you just go talk to them about it, most of the time it was a misunderstanding, just not educated about something, just didn't understand. And so generally speaking, I turn it back to the staff to go to direct it one-on-one with those individuals. And then if something can't be, if they can't come to a compromise, if there's still issues, then we'll take it to a more formal process. But most everything, we've had a couple really good outcomes by having me meet with staff. We kind of talk about it, I kind of give them advice and say, okay, now go try that. And they come back and say, hey, yeah, that worked. And it's usually just communication, which is overlooked.
So do you trust your staff with a task that you provide them?
Yes, so I have to. In this building especially, and even at MOI and Women's and Children's, I'm only in those buildings, especially like Women's and Children's, I'm there about 2.5 days a week. And at MOI, I'm probably there about the same 2.5 days a week. And then I'm here, but a lot of times I'm in meetings. And so I have to be able to trust the staff to carry out the jobs that we've asked them to do, because I'm not there watching them. And so I think that's where not micromanaging and macromanaging, let them have some responsibility. I hardly ever just say, yes, do this, no, do that, don't do this. I give the explanation behind it so that if the question comes up and I'm not here, then staff already have the tools they need. They say, oh, wait a minute, Bethany said we do this because X, Y, Z. And so that helps them make their own decisions. And so then, and we are, this environment is not for everybody. So because we have more complex environments, especially here, then we usually recruit staff that are ready to kind of take that challenge on. It doesn't mean somebody's not a good candidate or that a good therapist, but may mean this is just not the environment for them because it is pretty complex here.
What is the most difficult situation you've dealt with on a job? Like any job, not necessarily here at the hospital, but
most difficult. As a supervisor, probably my most difficult is when somebody is not meeting expectations for job performance, and then when you have to have those discussions and it could end in termination, that's probably my least favorite. I've had some really good results, some where I didn't think people could maybe turn it around, but after meeting with them, they did. But that's probably my least favorite, is when you have to meet with people who are just not quite meeting expectations.
Well,
Yeah.
what's your most memorable situation?
Oh my gosh. I've been at this like 17 years. I have all kinds.
You can name a few. It's okay.
Well, when I worked in home health, we had a screening process for employees. You had to have a background check for your drivers because that way our liability insurance. Well, we had a person who had been driving for us, and somehow they had never done the license check. So one day they called me and said, she can't drive for you anymore. Well, we had like 5 visits scheduled for her that day. We didn't have anybody else to make them. So I drove her around. And so I drove her to all her visits that day. And I can remember sitting in the car waiting for her at a house. And she came back out and had the strangest look on her face. And her patient had just been like wrapping the blind cord all around her walker and had like 22-liter bottles of soda and that she had just drank like 10 of them. And so just, I think home health always had bizarre situations, but that was the one. And we didn't know what to do with the patient because we thought we couldn't really do anything with her. We didn't think she's safe because her walker is all tied up with the blinds cord and she keeps drinking all this soda pop. For some reason, she thought she had to have all this soda. And so that was pretty fun. I had to drive her around temporarily, or I'd drop her off and a nurse would come pick her up until we could get her reassigned to inpatient therapy. And her license wasn't even in jeopardy. It was just that our liability insurance for the hospital felt she had like one too many ticket. Like it was going to come off of her license in 4 months or something. And so we reassigned her to inpatient, and I didn't have to drive her around anymore.
Do you remember your first time in leadership position, and where was it at?
So it was at Capital Region, where I worked in home health, and so it was as the therapy supervisor in home health. So back then I probably had there's probably 9 of us total, so much smaller than now. And
was it easier to work with a smaller group than it is with your 60 employees here? Or
I think yes and no. Probably easier in a small group just because when you look at things like communication and one-on-one time, really getting to know the therapist, that's easier because there's less. It was a little challenging because it was home health, so you didn't work with the staff either, so you didn't get to see them, except unless you made a special supervisory visit. So I would, every so often ride along with them and go make a visit. But then I always said, well, everybody's on their good behavior if I'm with you because I'm watching you. And so, but then sometimes it's hard in a smaller group because I think there's that need where you feel like everybody has to get along. Oh, we all have to love each other. We're in a bigger group, you just know that you're going to have 30 people. Right. Not everybody's going to love each other, but as long as we can be functional at work. And so I think communication is probably the hardest part. And that being able to personally connect with everybody is much more difficult in a larger group than smaller.
Knowing what you know now, would you do anything different?
Oh, man. Yeah, I mean, there's been a couple times, certainly, where I've where I've gotten a little bit burnt out, and it was more of a communication on my part, like not being able, I think when you're in leadership, you tend to just keep taking on more responsibilities, and you see it as a sign of weakness to say, hey, I can't do this task, I need, more time. And so that's been a challenge that I've learned to overcome a little bit better now, because that it's okay to say, hey, I can do that, but it's going to be a week, or hey, I can't get to that today, but I can get to it tomorrow. That ability to say, not no, but yes, I can. Other things. I'm sure there's things I could do better that I do better now than I used to, as far as just that HR part of being a boss, managing staff. I know there's probably things I would do different, but I try to not ever regret and learn and then fix behaviors going forward. So I think that most leaders learn, hopefully good leaders that stick with it, is because they've all done stuff they would rather that they later think, ooh, I could have done that better, but then they learn from it and then take that information with them. So
okay, what advice would you give for upcoming health professionals?
Be flexible, be willing to try new things. I think when you're looking at what employers are looking for, they're looking for energetic. We really like somebody that's after evidence-based practice and that stays up on the new techniques or what's going on, and that has a quest for knowledge and learning. Being very willing to say, yep, I can do that. Oh, I don't know how, but I'm very willing to try. Being open to new stuff. And then patient satisfaction is a huge part of healthcare right now because a lot of reimbursement is being affected by patient satisfaction, and so that's not something you always touch on in schools because it's more clinical based, and that's something that we are working on in therapy services a lot, is how do you maintain good patient satisfaction. So that's interpersonal stuff. That's not something you can always teach necessarily. And so that's the other thing is knowing that when you get out in the real world and you're a therapist, it's not all just about your clinical skills. Over half of it's going to be about your people skills. And I've been really surprised at patients' perceptions of our clinical skills based on just strange things. And so you think, I know we had a patient who we had to use lift equipment for because they were not very mobile and they probably weighed about 500 to 600 pounds. And so they were just very upset they hadn't had good therapy. And I went back and I looked at the notes and I'm like, well, they had a great therapy session. PT, sat them edge of bed, did a lot of exercises edge of bed, did some weight shifting standing. I'm like, that was a really good session that would have progressed that patient's mobility. We didn't get them up to the chair dependently with the lift. The patient was tired, so we laid him back down to rest. He did not think his therapy was good because we didn't get him up into the chair. And so it was sad that here therapy had actually done like an awesome job that was more useful than the dependent slide or the dependent lift to the chair. But in his mind, what the therapy did wasn't therapy. It was the getting up in the chair. So it was kind of eye-opening to kind of maybe including the patient. What is the patient's goals? Because you can do an awesome treatment session. We didn't get him to the chair. He didn't think he had an awesome treatment session. And so that's kind of sad, but a good learning experience to kind of make sure that we're kind of keeping in touch with our patients. And that's the stuff that's hard to learn in school because you're focused a lot on the hands-on clinical skills and not that other stuff.
So what healthcare challenges do you see coming in the future?
Reimbursement is a huge issue. I think if you accept Medicare patients, especially with the functional reporting with the G codes, the therapy cap, in Missouri we have lack of therapy coverage for Medicaid patients in most every setting except for inpatient rehab. This week or last week we got an email from Coventry, which is the university's insurance, that they're not covering therapy for children with a diagnosis of cerebral palsy, which is a huge diagnosis for us. Now, if you document that you're seeing them for ataxia and other issues, but with cerebral palsy, they're not going to cover it if you send something through. So I think just that reimbursement and kind of playing the game, and no matter what setting you're in, it pretty much touches almost every setting. Inpatient acute care is about the only setting that is underregulated as of yet because we don't bill directly for therapy, so we're kind of have a little carve out. But I would say reimbursement and everybody cutting back, looking for ways to cut back, especially under Medicare, and then different regulations that apply. So, and then patient satisfaction, pay for performance type. So a lot of organizations are going to be looking at their patient satisfaction really closely. And then readmissions, like on acute care, if you work in acute care facilities, your payment's going to be affected if you're getting patients readmitted 7 days or 30 days. So I think that focus on quality and then paying providers for quality indicators is a big thing, and it'll touch almost every environment. So
how are you preparing for that?
So we are preparing. So some of the things we need to look at patient satisfaction, we get our scores. Well, you can have them real time, little chunks at a time, or you can get them monthly. And then like in therapy services, we've started a few initiatives like on the outpatient world. They have like a patient education binder that they're putting together. On the inpatient side, we've done a lot of extra training with staff on different techniques. Some of it's just basics. Treat others like you would like to be treated. Seems simple. And we talk a lot too about our identity and who we are, and that when we hit that door, when you're coming in the morning, you're no longer you. I'm no longer Bethany. I am work Bethany, and that there's an identity that goes along with that. And if you stick with that identity, which focuses on the patient, that would help a lot. So we have a lot of energy around that. When we look at reimbursement, a lot of that is just staying up on all the regulations. We're really lucky here. We have a department that kind of focuses on that. However, we stay up to date. So we're on listservs. We get the information. We work closely with our billing office to try to stay one step ahead, so instead of playing catch up, that we kind of know what's coming. So that's the other thing, is really just staying involved in the national and state organizations, so that you can be an advocate, whether locally or on the national level, and that you can have a voice. They've had some success, in Missouri with the co-pays for physical therapy. equal pay for equal work. I think, I can't remember the exact name of the amendment, but they passed it recently here in Missouri. So being active in those type of movements, so where you can know what's going on in the world. Let me think what else. Saying evidence practice. So when you're doing your interventions, there's things like whirlpool that have been done forever. We still do a little bit of whirlpool here, but the evidence doesn't really, support it. We don't use a lot of modalities in outpatient. When you go and look, it's so I think just being a smarter clinician, looking at the interventions you're giving and staying up with what evidence is saying is most effective. So.
Okay. Well, I think that's it for us. So.
I talk really fast, so that helps. You are doing a great job, Maddie, taking notes, because I talk really fast. That's why you have to record it.
Thank you so much. Yeah. It was a pleasure.
No problem. Glad to help.